Hi students, this is Ramya from Department of Pharmacy Practice. Today in this session, we'll discuss about organophosphate poisoning, which is in fourth year PharmD clinical toxicology. First, we'll see contents, what we are going to see in this class. First, contents. In contents, we'll see introduction to organophosphate poisoning. In that, we'll also see uses, physical appearance, classification based on its toxicity and fatal period. Next, we'll see toxicokinetics. In this, same like pharmacokinetics, we'll see toxicokinetics. Next, mechanism of action. In this, we'll see how toxicity occurs. Next, toxic symptoms or clinical symptoms. Next, we'll go for diagnosis and treatment or management. In treatment, we'll see antidote, which is given for organophosphate poisoning, and the supportive and symptomatic treatment. So, first, we'll go for introduction. Introduction to organophosphate poisoning. Organophosphate poisoning is a most popular and most widely used insecticide in India. This is the most commonly used in developing countries, as our India is a developing country. These organophosphates are phosphoric acids esters, and these main action is to inhibit acetylcholinesterase. By inhibiting acetylcholinesterase, there will be a more accumulation of acetylcholine, so that it shows muscarinic and nicotinic effects. In mechanism of action, we will see in detail about this organophosphate poisoning. Okay, this poisoning is not only for insects, this also for humans, because these organophosphates are used for as insecticides. Next, physical appearance. Physical appearance of various organophosphates. These organophosphate compounds are available as dust, granules, or liquids based on the different compounds. Some products are diluted with water before use, and some are burnt to make smoke that kills insect. Next, we'll go for classification. This classification is mainly based on its toxicity and clinical use. There are 100 number of organophosphate compounds that are available, but in that they are classified according to their toxicity. First, highly toxic organophosphate compounds. In highly toxic organophosphate compounds, examples are tetraethylene pyrophosphates and parathione. These highly toxic organophosphates uses agriculture insecticides. Next, intermediate. Intermediate type of organophosphates are trichlorophon. These are used as animal insecticides. Next, low toxicity. Malathion, diazinon. These are used for household applications and as field spray. See, different. There are many number of organophosphates that are available in market. They has different uses. Some are used as insecticides, some are used as pesticides, some are used in household applications, and some are used as field sprays. Next, we'll go for fatal period. Here, fatal period based on the individual. See, less than 2 days or in between 2 to 7 days for patients who are on ventilation. So, they are at more risk. Next, pharmacokinetics. In pharmacokinetic, first absorption. Absorption by any route. It may be in transdermal, transconjunctival, inhalational, recrosa G and GU mucosa, and through direct ingestion. These compounds are highly lipid soluble, crosses blood-brain barrier, and metabolized in liver and esterase hydrolysis. Next, we are seeing mechanism of action. Here, the important thing in organophosphate is mechanism of action. How it shows toxic effects. First, as I already said you, organophosphate will inhibit the acetylcholinesterase enzyme. So, what is the main function of acetylcholinesterase that we'll see first? See here in this diagram, see presynaptic neuron. This presynaptic neuron and postsynaptic neuron, this releases acetylcholine. This acetylcholine. See here, acetylcholine esterase. Sorry, acetylcholine, and this is acetylcholine esterase. This acetylcholine released from presynaptic neuron is breakdown into acetate and choline. Whereas by inhibiting this acetylcholinase, so there will be a more accumulation of acetylcholine. So there will be more accumulation of acetylcholine. It shows muscarinic and nicotinic effects. See here, see organophosphates are acetylcholinesterase inhibitors, so that accumulation or increase in acetylcholine in synaptic cleft. So, overstimulation of acetylcholine receptors causes signs and symptoms of organophosphate poisoning. So, what are the toxic features? Till now, we have seen mechanism of action, how it gets affected, what are the symptoms it shows. So, from the mechanism of action, now we are going to clinical features or toxic effects. In clinical features, first, clinical features begin within few minutes or few hours, or it may be delayed up to 12 hours. It's based on the different organophosphate compounds. So, in clinical features also, we are seeing acute poisoning. Next, we are going to chronic poisoning. In acute poisoning, first cholinergic excess means overstimulation of acetylcholine. So, it shows muscarinic nicotinic effects. First, muscarinic effects. Here, I wrote sludge. Why I wrote sludge? This is a mnemonic to remember the muscarinic effects. So, sludge. See, S. S for salivation, L lacrimation, U urination, D diarrhea, B bradycardia, GI distress, and emesis. So, by the is mnemonic, you can remember the muscarinic effects and other effects also you can see. Pulmonary edema, cough, bronchoconstriction with wheezing and dyspnea, hypotension, vomiting, bronchospasm. Next, we will see nicotinic effects. In nicotinic effects, first in nicotinic effects, we should remember muscle weakness. Next, fasciculations, paralysis effects, next CNS depression, respiratory depression, seizures, and coma. And in nicotinic effects, tachycardia is most common, and hypertension can occur up to 20% of patients. So till now we have seen cholinergic cases, in that muscarinic effects, nicotinic effects. Next we will see CNS effects. CNS effects means, in this we will say headache, tremor, drowsiness, delirium, slurred speech, ataxia, and convulsions. Coma in the later stages in some cases. And here we can also see intermediate syndrome, delayed syndrome. Intermediate syndrome, it causes after 1 to 4 days, causing muscle weakness and paralysis. Whereas delayed syndrome, it occurs after 1 to 5 weeks. So it will take a time gap to show the symptoms. Next, chronic poisoning. In chronic poisoning means, if a person is exposed for a long period of time. So it is more common in agriculturists within 1 to 6 weeks. And what are the symptoms of polyneuropathy? Here CNS effects are drowsiness, confusion, irritability, anxiety, sheep farmer's disease, and chronic organophosphate induced neuropsychotic disorder. So, this is the clinical features of organophosphate. We have seen acute poisoning and chronic poisoning. Next, we'll go for diagnosis. So in diagnosis, how you will till now we have seen from introduction to clinical features. Now we will see diagnosis. How we can diagnose is a patient is organophosphate poisoning patient or not. So based on that, we will give treatment. So first, here in diagnosis, first we will see depression of cholinesterase activity. That is, if the RBC cholinesterase level is less than 50% of normal, so it indicates organophosphate toxicity. Same as a depression of plasma cholinesterase level less than 50% to its normal, it is also one of the indicator of organophosphate toxicity. Next, p-nitrophenol test. This is one of the test. In this, a metabolite of some of the organophosphates can be identified in urine. Next, TLC, thin layer chromatography. By this TLC is used to determine the organophosphate in the sample. Like it may be lavage or vomiting or gastric aspirate sample. Next, other investigations are ancillary investigations. In that, we have to monitor electrolytes, ECG, and severe pancreatic isoamylase levels in patients with significant poisoning. If respiratory tract irritation is present, should monitor chest X-ray. Next, HPLC technique can be used to identify several organophosphates in human serum. These are the different diagnostic tests. By that, we can indicate whether it is organophosphate toxicity or not. So, if we indicate it is an organophosphate toxicity, then we will go for treatment. What is the treatment required for that patient? So, next, we'll go for antidote. For many toxic compounds, there will be an antidote. So here for organophosphate, antidote is atropine and it is followed by pralidoxime. Atropine. Here you have to remember that atropine, it shows effects on muscarinic receptor, whereas it does not show any effect on nicotinic receptor. Whereas oximes, it shows its effects on nicotinic receptors. Atropine for muscarinic receptors, oximes for nicotinic receptors. So in this, here it will blocks the muscarinic and it will decreases the manifestation, muscarinic manifestations of organophosphates. Here, atropine 1.8 mg bolus is given immediately after get diagnosed with organophosphate toxicity. By 1.8 gram bolus immediately, then should double the dose for every 5 minutes until atropinized. And it may require about like until atropinized, it may require about 40 to 150 mg per day for at least 5 to 7 days for the patient. Next, oximes. As I already said, oxime, it shows effects on nicotinic receptors, means it reverses nicotinic features. And this pralidoxime dose is 1 gram bolus in 30 minutes. Then infusion of 0.5 gram per hour. But even in some cases, if the treatment is began earlier with atropine and oxime, but the mortality of organophosphate poisoning is generally extent up to 7 to 12%. It's based on the patient's complications. Next, here I have mentioned anticholinergic, right? Anticholinergic symptoms. In that, muscarinic symptoms, nicotinic symptoms, and CNS effects. See, in muscarinic effects, I have said sludge. Okay, next, nicotinic muscle weakness, muscle fascinations. Next, CNS, headache, dizziness. See, for I have already said you for muscarinic effects, antidote is atropine, it shows effects on muscarinic features, whereas oxygen it reverses nicotinic features. For CNS, we are given diazepam IV, and oxygen and ventilator support is given if needed. Next, we will see general treatment. How the patient is treated. First, initial stabilization of the person by ABC analysis. You already studied in your last classes that ABC. What is ABC? Airway, breathing, and circulation. So first, clear airway. Next, adequate ventilation or oxygen therapy also given if it is needed. Next, main thing is it is a reduction of exposure. Next, decontamination. How we will decontaminate? By washing dermal areas with mild soap or removal of contaminated clothes. For high exposure, you have to rinse the eyes with normal water or saline or necessary for dermal and ocular exposures. Next, activated charcoal is an initial supportive measure for organophosphate intoxication. And endotracheal intubation and mechanical ventilation may be necessary in organophosphate poisoning patients. As we already studied, atropine and pyridoxines are used as antidote for organophosphate poisoning condition. Diazepam is used to control seizures and CNS related effects. IV infusion of sodium bicarbonate produces moderate alkalization. Next, dextrose 2 to 4 ml per kg of 50% dextrose is given. If any infections, mainly to prevent pulmonary infections, antibiotics are given. Next, and finally, vitamin K may also be given if needed. In chronic poisoning, also the general treatment is same for both acute and chronic poisoning. But for chronic poisoning, symptomatic treatment and supportive measures are very important. And in chronic exposure, as I am already telling, it's a chronic exposure, means exposure of long period of time. So, removal of patient from the source of exposure is important in chronic poisoning condition, and supportive and symptomatic treatment is given, uh, and finally antidote is given for the patient. Next, last, thank you. By this we have completed organophosphate poisoning. Thank you.